Welcome to the talk with Dr. Peter Rowe. I'm Tess Fahler, and I'm founder of Renegade Research. We're a new nonprofit, and we are patient-led. We do research of distributed self-experiments and polling data. And our biggest project, which many of you have likely heard of, is Remission Biome. And Remission Biome currently has 50 self-experimenting patients working together to try to understand how to trigger remission events in ME/CFS and long COVID and increase baseline function afterwards. So there's a lot of people from our team here today, and I just wanted to thank everybody who is here. We like I said, we're a nonprofit. We have a lot of volunteers, and we couldn't do it without all of you. So just recognize everybody who's on the team here. And I'm going to pass it off to Isabel. Isabel is the CEO of our nonprofit, and she's been very involved in Remission Biome and Renegade Research from the start. And she has started another series of these similar webinars to this for clinicians. It's going to be the Clinicians Roundtable. So I just wanted to pass it off to her quickly to give a little pitch of what the vision is for those.
Yes, welcome everybody. Thank you for being here. Just wanted to invite you all to our roundtable, our Clinicians Roundtable, which will be starting March 15th. And that'll be at 1 o'clock Eastern. And the purpose of the Clinicians Roundtable is to have expert clinicians who are treating ME/CFS, long COVID, and post-infectious conditions to really discuss what their clinical practice is, how they treat patients, and how they see their quality of life improve. And for clinicians who want to learn how to navigate the world of ME/CFS and long COVID, to be able to learn from those experts and expand the pool of clinicians who are treating patients. It is also open to patients who want to listen in and bring that information back to their own clinicians to broaden their expertise. So I encourage everyone to attend.
Thank you. And I will mention now, if you go to our website, remissionbiome.org, you can sign up for our email list, and we'll be announcing all of these clinical roundtables and other talks through the email list. The other type of talks we have, we'll be calling research roundtables, and this has been an internal research meeting that we've been having for Remission Biome, where we have this amazing community of people in many different disciplines coming together. And we have a talk about a specific topic related to Remission Biome, and then we get good discussion between people. And so it's been really fun to do these internally and sort of invitation only, but we're going to be opening these up to the public so that more people can learn more about the science of ME/CFS and long COVID. And Kat, one of our team members here, is in charge of those meetings. Did you want to mention anything more?
Oh, it's a great place to, if you have one of those theories bouncing around where you see things starting to line up and you're not quite sure, this is a great place to come together and share those ideas with people who might know more about the topic, to be able to bounce those back and forth. And we've had a lot of very good models come out of it that have since gone on to be their own research projects.
Yeah, and I'll mention that we're recording these talks, and we'll be making them publicly available for people who can't attend real time like this. So mentioning that, this is being recorded. This will be posted publicly. And so if you end up, coming up and speaking on video or audio and during the Q&A session, or if we, read off your questions and you don't want that to be made public in the recording, email communications@remissionbiome.org. And we will edit the video afterwards. So we just want to make sure everyone feels comfortable in this meeting. Okay. So the way that this will work, Dr. Rowe has a lot of material to cover. This is just part one. Will there be a part two next week? So he's going to go through the material first, and then we'll do a Q&A session at the end. And the questions will come from the the Q&A at the bottom of your screen. You can see the little Q&A button. You can type in your question, and then we're going to have people upvote for which questions that we want answered at the end of the talk. So you can go ahead and type in your questions and upvote as Dr. Rowe is talking, and then we'll get to those at the end. So now I would love to introduce Dr. Peter Rowe. He's the director of the Children's Center for Chronic Fatigue Clinic, and he's a professor of pediatrics at Johns Hopkins University. He has interest in ME/CFS, fibromyalgia, Gulf War illness, pelvic congestion syndrome, hypermobility syndromes, including EDS, orthostatic intolerance, including POTS. And recently, Solve ME honored him in April of last year for his work as a provider, researcher, educator, and advocate for ME/CFS and long COVID communities. And this is actually my first time meeting him, but I have heard great things about him from patients. And so reading his amazing research papers and hearing from patients, I think that he's the perfect person for us to have to present to us today and get this conversation started. So I will pass it off to you, Peter, if you want to present your slides now.
Yeah, great. Thank you very much for inviting me, especially to Ellie, who goes back a long way with our group. Let me bring up my slides here. All right. So Ellie wanted me to speak about what's new in ME/CFS, and I picked a few topics that we'll cover. The two that we'll do today are orthostatic intolerance, and especially its effect on brain blood flow. And then the second will be venous compression syndromes. And then next week, we'll talk about some things that we've been working on in our clinic for a long time that seem to make a difference. One being biomechanical strain or issues with tightness in the body. And that includes thoracic outlet syndrome as one example. Then there's been a lot of interest of late in neuroanatomic problems that often benefit from surgery. And we'll talk a little bit next week on mast cell activation syndrome. But I wanted to take a trip back in time. We got started on this work with a number of patients who were coming to see me in my diagnostic problems clinic who had either chronic fatigue but didn't meet chronic fatigue syndrome definitions at that time, or they had full-blown CFS. And we thought, you know, these kids are getting into trouble in the same positions that others develop fainting. So standing in a line, standing in a hot environment. And we approached Hugh Hopkins, who's shown with the glasses in the slide. He's the head of the Johns Hopkins Tilt Lab. And he was willing to put our patients on the tilt table. The work was done with Jean Khan, who's on the left, and Issam Bouhalega, who's a fellow with her from Saudi Arabia. And all 7 of these patients, consecutive patients, had a big drop in blood pressure on the tilt table. We reproduced their symptoms, and 4 of the 7 got better with medicines that are usually used for treating recurrent fainting. So we thought we were onto something, and we started planning a bigger pilot study that would help us estimate a sample size needed for a randomized trial of Florinef. But what was curious at that time was that patients from Baltimore had been so upset with the Hopkins approach, which up until that time had involved sending them all to psychiatry, that none of the people in the Baltimore support groups wanted to participate. So we started casting the net wider, and we met Ellie Brocious and Katie Lucas, who were support group leaders, Ellie in Northern Virginia and Katie in Richmond. And they were responsible for recruiting most of the patients that we then enrolled in our next couple of studies. Ellie felt a little bit better at one point, and she volunteered to come into the office. And at that point, we needed her to do some Xeroxing in the library. That was quiet standing that was a bit too much for her. So when she came back to my office, she had to lie down and get better control of her symptoms. But in the process, she was able to find something that had slipped under the desk that had valuable information on it. So as she said, lying down when you need to often brings a service to the world. So I wanted to just give my thanks to Ellie for her more than 30 years of advocacy on behalf of people with these illnesses. I love the t-shirt. Really, I'm fine, says the cow upside down. Ellie and Katie also encouraged us, as we are seeing new patients and learning more about ME/CFS, to start writing down things in a brochure. And this has gone through many iterations. The 2014 version is the one that you can find online at the Dysautonomia International website. But they were really instrumental in not only suggesting that we get going on this, but giving us tips about how to orient and suggest drug treatments, meaning start at a low dose and go up slowly. What we're really pleased to announce is that that has now been transformed into a full book, and that's going to be coming out from the Johns Hopkins University Press later this summer. So again, Ellie, many thanks for what you got started in motion. Our team now, the team for 27 of the last 30 years was just me. But we now have had enough philanthropic contributions that we have a real team, including Renee Swope, who's the clinic nurse, Megan Swope, who's the research associate. In the front, you see Dr. Camille Broussard, who's an adolescent medicine specialist who's joined us, and Dr. Alba Azola, who many of you may know from her work in the long COVID space. Alba helped put together a new website that's listed here, and that includes many of the papers that have come out from our group over the last 30 years. So those are available, many of them are available to download if you'd like to see that. When we meet with patients, we often show them this diagram, which summarizes our understandings of the approach to treatment of ME/CFS. We think a big factor is orthostatic intolerance. It's perhaps the most treatable thing that we find in our patients. But as you can see from the diagram, there are many other things that influence either the orthostatic intolerance or the ME/CFS. And I'll pick out a couple of these in the talks that we're going to be doing. But one of them is food allergies. We've found that 31% of our patients have an intolerance of milk protein that we need to clear out of their diet before they have a chance to get better. And things that include problems like hyperhidrosis or excessive sweating. So each person brings their unique combination of these problems to the clinic. In the next two sessions, today and next week, we'll be talking about some of these in particular, especially the orthostatic intolerance, but also the neuroanatomic problems, the movement restrictions, the vascular compression problems, and mast cell activation. So let's get on with the orthostatic intolerance piece. With each of these, Ellie asked me to present a case to make this a more practical discussion. So I want to talk about a 22-year-old who I saw first when she was 17. She'd had the onset of her illness with a mononucleosis that was caused by cytomegalovirus, or CMV, and her main symptoms were fatigue, sore throat, and an enlarged spleen. So she was 14 when she first got sick. And then by the time I first saw her 3 years later, she'd already been diagnosed with orthostatic intolerance. And that was diagnosed based on symptoms, but also a 10-minute passive standing test that's shown on the bottom right. And you can see that after 5 minutes lying flat, she stood up leaning against the wall and immediately got lightheaded. She became very hot. Her fatigue and headaches increased, and she had this purple discoloration of her limbs called acrocyanosis. Note that for 17, you need a 40-beat increase in heart rate. Her heart rate increased 38 beats, but she was already partially treated at the time of testing. She was on Cymbalta for some mild depression and pain, and on birth control pills, which can affect this. Anyway, she had, in addition to the orthostatic intolerance, she was quite flexible. She had hypothyroidism, but treating that hadn't made her better. She had Raynaud's phenomenon, migraines, and then this sense of tightness on the physical therapy examination. She was a very, and is a very gritty young woman, and she she got through high school and college mainly on fumes and grit, but nothing that we did helped her headaches. She got a little bit of help from increasing salt and fluids and using a body shaper compression garment to push blood up from the abdomen and thighs. But we tried all of the medicines listed on the right, fludrocortisone, midodrine, stimulants, beta blockers, pyridostigmine, clonidine, and birth control pills, and we just didn't see any real benefit. By the time she was 22, her heart rate at rest was between 104 and 140, when it should have been somewhere in the 60 to 70 range. And anytime she tried to exercise, and she'd been reading these articles that said, you know, you can exercise your way out of POTS. And so she kept trying to go to the gym. But every time she went on the elliptical, she would get a marked increase in her heart rate within 2 to 3 minutes. Her heart rate would bump up to 180. And that would provoke a 2-day migraine episode. And I said to her, look, Samantha, you've got to stop doing this until we can control your circulation better. You just aren't able to exercise. So then along came ivabradine, a drug that was introduced to treat heart rate, excessive heart rate in people with heart failure. So we got access to this and noticed that on none of the drug, her resting heart rate was 115. It would go up to 180 within 2 minutes of starting to exercise and provoke this headache. By the time she was on 5 milligrams twice a day, heart rate was nicely down to 90. She would get up to 155 on the elliptical, but now could do it for a while without getting a headache. And her optimal dose turned out to be 10 milligrams twice a day. So her resting heart rate was quite normal at 72. And heart rate would only go up to the 130s with 40 minutes on the elliptical without a headache. Now, some of you remember the older, somewhat less impressive history of the behavioral attributions of these symptoms that many psychiatrists in the United Kingdom and Europe would use. So they thought that ME/CFS was a psychosomatic disorder, ignoring much of the data on these physical exam problems that nobody could possibly have faked. At any rate, they would claim that once you get these lazy bums to exercise, they'll be fine. That'll cure their ME/CFS. So here's somebody who's totally fit, right? She works in Phoenix, takes a weekend trip to Sedona, does 10 miles of hiking in a day, sends me this picture. Problem was that the insurance companies didn't allow us to use this drug in perpetuity. They wanted a new prior authorization every summer. So here she is fully fit. But when she was off the medication, as we tried for 2 weeks to get it reauthorized, she would immediately get back to fatigue, lightheadedness, and brain fog. So she's a nice example of the fact that we were managing her circulation, but we hadn't cured anything. And it is completely fallacious to say that all one needs to do with these illnesses is just exercise your way out of it. She simply couldn't do that. It was only by treating her that she was able to allow herself to enjoy other physical activities. So when we think about what we know regarding the relationship between orthostatic intolerance and ME/CFS, we know now that orthostatic stress, that is being upright, can provoke the cardinal symptoms of the disease, and that includes the fatigue, the exercise intolerance, lightheadedness, brain fog, and it's turned out post-exertional malaise is also something that you can provoke by being upright. Ellie remembers that we did this during the tilt testing in the early days. We noticed that patients were often very symptomatic for several days afterwards. And in order to fix that, we started giving people 2 liters of IV saline right after their tilt test. And that not only gave them it prevented the PEM, but they felt better when they left than when they had come in, emphasizing the importance of salt and fluids in their care. Unbeknownst to us, some of these observations had been made as early as 1940. This was a paper by McLean and Allen, who had noticed that orthostatic hypotension and tachycardia, or fast heart rate, were present, and they said that these syndromes were characterized by an excessive acceleration of the heart rate when the patients went from recumbent to the erect posture. And they said that orthostatic exhaustion, blurring of vision, weakness on exercise, and even fainting episodes may occur. And they called it a syndrome that was identical with effort syndrome, irritable heart, or neurocirculatory asthenia, which were the names in that era for ME/CFS. And they treated people only with very high amounts of sodium in the diet, plus elevation of the head of the bed, which prevents you from urinating as much at night. So people would awaken with a better blood volume. They then went on to say that these syndromes were due to defects in the return of venous blood to the heart. So too much pooling of blood in the lower half of the body. And this is essentially where we are still today. Some people will know the work by David Systrom using the invasive cardiopulmonary exercise tests. And those show essentially that there's a preload failure. Well, preload is just the medical jargon for not enough blood getting back to the heart. And so these two anticipated a lot of our modern understandings of the illness. Let me move on to talk about the common forms of orthostatic intolerance. The one that you saw in the other patient, or that she was very close to having, was POTS, or postural tachycardia syndrome. That's defined as a 40-beat increase in heart rate if you're an adolescent, but if you're 20 and older, you only need a 30-beat increase in the first 10 minutes of standing or head-up tilt testing. And it's not just a heart rate change. It has to be associated with chronic orthostatic symptoms like lightheadedness, fatigue, and brain fog. And you can't have a big drop in blood pressure in the first 3 minutes that would be consistent with a different type of orthostatic intolerance, orthostatic hypotension. The pattern that we saw much more commonly early in our work, before people knew to increase their sodium intake, was the neurally mediated hypotension that you see on the right. This is the same as vasovagal syncope or neurocardiogenic syncope, but not all of these patients have fainted in day-to-day life. So we called it neurally mediated hypotension. And on the right is a very early development of this problem where the individual had been supine for 5 minutes, or 15 minutes actually, on the tilt table, came upright to 70 degrees, immediately got lightheaded and pale. And then, as you can see at the 5-minute point, the blood pressure bottoms out and heart rate slows at the time of the drop in blood pressure. And she even had some seizure-like movements. So this is usually something that happens much later in the tilt, but this individual had it happen at the 5-minute point. Whatever form of orthostatic intolerance you have, these are the kinds of symptoms that it will cause. And the ones on the left are thought to be due to reductions in the amount of blood flow getting to the brain. So that makes sense for lightheadedness and fainting, but also it can create symptoms that very much look like you've just suddenly acquired attention deficit disorder with diminished concentration, poor short-term memory, word-finding problems. Headaches are common, as is blurry vision. And in all forms of orthostatic intolerance that I've identified, there's a higher prevalence of both fatigue and intolerance of low-impact exercise. The symptoms on the right are often thought to be due to a high catecholamine or adrenaline response to that reduction in brain blood flow. So that includes an orthostatic shortness of breath or dyspnea. Chest pain and palpitations are common. And then often there's a higher prevalence of tremulousness and anxiety. We know that experimentally we can cause a panic attack if we give a lot of adrenaline-like material to patients in research studies. And patients with orthostatic intolerance have a very high level of these catecholamines. So it's not surprising that they also can have a bit more in the way of anxiety. You can also see GI symptoms as well as urinary problems. So I mentioned the study at the top. The study that Ellie helped us with got published in the Journal of the American Medical Association. And one of the things that was evident in that study was that we had 23 adolescents and adults with ME/CFS and 14 controls, and they were all brought up to the 70-degree angle on a tilt test that you can see in the upper right. And for all of the patients, this brought on a bad day with their ME/CFS symptoms. They all had worse fatigue. Many had worse lightheadedness and felt hot and nauseated. whereas the controls for 45 minutes on that table were simply bored. When we looked at how many of them developed a drop in blood pressure, that's what I mean by abnormal. 16 of the 23 had that in the first 45 minutes upright versus none of the controls. And so the odds ratio for having an abnormal tilt, for developing hypotension on the table, if you had a diagnosis of ME/CFS, ended up being 55. And when you do an estimate like that, based on your sample size of your study, you can also generate a 95% confidence interval for whether that estimate is correct. So even our lowest, most 95% confidence interval was 5.4. And for those of you who are unfamiliar with odds ratios, the odds ratio for cigarettes causing lung cancer, it's 2.7. So this was a huge difference between groups. The other thing that we saw was that many of the patients had this kind of acrocyanosis, this purple discoloration of the dependent limbs. On the left is somebody whose hand is turning purple, reddish purple after 5 minutes upright. That's my hand behind hers for contrast. And on the right, I've taken my fingers, I've pressed on the skin to look for what we call capillary refill. Normally, any area you compress should have blood coming back to it within 3 seconds. But I pressed on her skin, went back to the table, picked up my camera, found the camera icon, focused, and took the picture. So 7 or 8 seconds elapsed, and she still didn't have capillary refill. So we see this physical finding in about 75% of our patients. Again, a physical finding that nobody could possibly have manufactured on their own. The other thing that drew attention to this paper is that we decided to treat these individuals with a variety of different medications that were used at the time for recurrent fainting. So that included fludrocortisone or Florinef, midodrine, beta blockers, and other medications. And what we used as an outcome measure was a thing called the wellness score that is anchored at 0 for I feel like I'm dying and 100 for as good as I can imagine feeling. You can see that this was a pretty impaired group with a mean wellness score of just 35 out of 100 at baseline. But after 4 months on treatment, the improvement was up to 70, some people even having a complete resolution of symptoms. And this, in many ways, is about what we continue to see to this day. And this is why I refer to treating the orthostatic intolerance as one of the most effective ways of improving symptoms and function, both in ME/CFS and in long COVID. Others have replicated this work. This was a nice paper from Julia Newton's group in the United Kingdom, where they used the COMPASS questionnaire of autonomic function. And you can see a huge difference between the CFS patients and the controls on their COMPASS score. And also on the right, that the COMPASS severity correlates with the fatigue severity. When we went to summarize the international literature on orthostatic intolerance for the Institute of Medicine report in 2015, we found that the rates of orthostatic intolerance were not as high as what we had found in our work. Others, and this is meant to be an unreadable slide except for the part at the bottom, the others only found 42% of adults having hypotension or orthostatic intolerance versus just 15% of controls. So we've learned from others, including Marvin Meadow and Julian Stewart, who are shown here, that as you increase the amount of upright posture, it impairs your cognitive abilities. This is a study done by colleagues Linda Van Kampen and Frans Visser. They're cardiologists in the Netherlands, and they showed that depending on which kind of complexity of cognitive test, one was called a 2-back and the other one a 3-back test, the more things you have to remember, the harder the task, that after people finished a tilt test, they were much, much foggier. And they showed that fogginess continued to increase compared to before their tilt test. And so they were still having problems 7 days later. So this is, again, evidence that upright posture can provoke post-exertional malaise. They were treating their symptoms this evening when they came to Baltimore with crabs and the rock salt that the crabs are sitting in. So the symptoms of orthostatic intolerance are largely due to the reductions in blood volume and in the venous return to the heart, which then lead to brain blood flow reductions. So this slide summarizes a lot of the physiologic literature, pointing out that people who are at risk for orthostatic intolerance, for some reason, have excessive pooling in the lower half of the body. Maybe their vessels don't constrict as effectively. They often have about a 10 or 15% reduction in the amount of blood in the circulation for reasons that are unclear. And those two things combined lead to this massive reduction in cerebral blood flow. That elicits a big sympathoadrenal response, and then you get one of the forms of circulatory dysfunction that you see on the bottom. So you can have orthostatic hypotension that occurs within the first 3 minutes of being upright, delayed orthostatic hypotension, which occurs after that 3-minute point, but is the same type of reduction of 20 millimeters of mercury systolic or 10 diastolic, neurally mediated hypotension you've seen, POTS you've seen, and then we're learning that many patients who have a lot of orthostatic symptoms actually have a normal heart rate and blood pressure, raising questions about whether those are the accurate things that we ought to be looking at in making a diagnosis. We had tried to show that brain blood flow went down using a thing called transcranial Doppler. This is an ultrasound that beams into the middle cerebral artery through the bone in the temples and picks up blood flow velocity. Problem with that is that if the vessel narrows, you could have a big reduction in blood flow to the brain, but by narrowing the vessel, the velocity stays the same. So in our study at Hopkins in 2003, we showed virtually no difference in cerebral blood flow velocity using the transcranial Doppler between our ME/CFS patients and the healthy controls, even though our ME/CFS patients were way more symptomatic on the tilt table. So this just wasn't a very effective way of measuring what we thought was happening. Then along came Dr. Van Kampen and Dr. Visser, who I met at a meeting in the United Kingdom in 2017. They had done a really neat thing. They picked up their Doppler probe and they were able to measure for about 30 or 40 seconds blood flow through each internal carotid artery and each vertebral artery. So over the course of 2 to 3 minutes, they could tell you what the total blood flow to the brain was. So here's an example of their ultrasound measurements. Here's somebody lying flat, and you can see each beat that this is the amount of blood flow going through that vessel. Notice that when they stand, it's a big reduction. You don't have to be an ultrasound expert to see that difference. So they had gathered data on hundreds of their patients. I helped with some of the English language writing, and I helped break the ties between this husband and wife team. But this paper, I think, is one of the more important ones that I've been involved with in my career, because what they looked at was 429 adults with ME/CFS. They had 44 controls. Most of these individuals had daily symptoms of orthostatic intolerance. All of them met the Fukuda criteria for chronic fatigue syndrome. And when they were tilted upright, remember from the IOM report that was published earlier, that about 40% of people had some demonstrable orthostatic intolerance when you just looked at heart rate and blood pressure. And the same was the case here. 28% of their population with ME/CFS had POTS, 14% had delayed orthostatic hypotension, but 60%, close to it, had a normal heart rate and blood pressure response, but symptoms. And they would have been at risk for being told that, there doesn't seem to be anything wrong with you. Turns out when they looked at the cerebral blood flow measurement using their extracranial Doppler, that if you look at healthy controls over 30 minutes on the tilt test, there's a 7% reduction in brain blood flow on average. That makes a certain amount of sense. We've all been lightheaded when we stand up. If you take the entire 429 with ME/CFS, they had on average a 26% reduction. So almost 4 times worse brain blood flow. When you break that number down, the ones who had POTS or delayed orthostatic hypotension were a bit worse, but that 60% of them who had a normal heart rate and blood pressure response nonetheless had a 24% reduction in brain blood flow. And all of these guys were the same as the healthy people when they were lying flat. They showed also that the percent of reduction in cerebral blood flow correlated with the number of orthostatic symptoms during the tilt. And one of the papers that came out just last year from their data showed that the reason we might not be seeing as much POTS in this group is that once they'd been sick for a while, they lost the ability to increase their heart rate. So this is a complicated slide, but it looks at the reduction in stroke volume, the amount of blood that the heart is ejecting. And when you get a reduction in stroke volume, you should see a compensatory increase in heart rate. And so that's what you see in the blue dots, which are the healthy people. And this is the slope of the relationship between the stroke volume and heart rate. Notice, though, that the slope in red of the ME/CFS patients was vastly different, and about 40% of them actually had a very low, outside of the normal bounds for healthy people, increase in their heart rate, something called chronotropic incompetence. So they couldn't have gotten to the point of having POTS. And again, this emphasizes the importance of looking at symptoms rather than the heart rate and blood pressure criteria alone. They've shown that people who are hypermobile have an even greater degree of cerebral blood flow reduction than the ones with ME/CFS who are not hypermobile. And they've extended this work to their patients with long COVID, showing that none of the symptoms are any different between groups. And importantly, that they also have pretty bad reductions in brain blood flow. So at the bottom, you've got a healthy person, supine. This is the same vessel when they're upright. That's an 8% reduction. On the top, though, you see somebody with long COVID, and they have a reduced carotid artery flow at baseline, and it goes down 39% when they're upright on the tilt table. I don't know how they were able to continue standing. So this shows that when they looked at their long COVID group compared to people in their database who had ME/CFS and POTS on the tilt table or a normal heart rate and blood pressure response, the long COVID people all had POTS, and they were even worse off. And some people will say, well, all this orthostatic intolerance is just from deconditioning and inactivity. But these guys had only been sick for about 6 months. These folks have been sick for 5 years on average. They should have been way worse if that was an adequate explanation, which it obviously is not. All right, so that's some of the interesting work on brain blood flow as a major problem in ME/CFS. I'm going to move on to a related topic now of the venous compression syndromes. So let me start off with a couple of cases. This one was a 16-year-old girl who had Ehlers Danlos syndrome, met criteria for ME/CFS and orthostatic intolerance. And she developed this 2-year history of really disabling back and pelvic pain. The pain would get worse as the day went on, and it would be present with urination, and she had a lot of urinary urgency. And the pelvic pain was occurring when the back pain was present. And it was so bad that this girl couldn't even sit upright in her chair at school. They had to put a mattress down on the floor for her to be able to attend. She would get some lower abdominal distension and outpouching as the day went on. All of the standard imaging studies were normal, and she didn't respond to any of the medicines we gave her, including inpatient evaluations. This was a second patient with the same problem. She had Ehlers-Danlos syndrome with chronic fatigue, and she was a medical student at Hopkins at the time. She'd been having some problems with fainting, but only a couple of times a year. Then as she sat down all day in medical school, she was much more lightheaded, and she would get 2 episodes of near fainting each week and was lightheaded many times each day. She'd get worse fatigue after she fainted. And initially we tilt tested her, and hers was the vasovagal, the neurally mediated hypotension pattern I showed you earlier. She had the faint after 5 minutes, and we treated her with salt and fluids and midodrine. But she came back a year later because of this pelvic heaviness and low back pain, and she was worried that she was not going to be able to tolerate her surgical clerkship during medical school. Well, what these 2 women had was something called pelvic congestion syndrome, which is more common in women. It's a pelvic heaviness or pain the longer you're upright, so it's worse at the end of the day. And in the past, it was noted that these people had chronic fatigue, low blood pressure. They had dyspareunia, which is the medical term for pain with intercourse or even tampon insertion. And they often had bladder urgency. And because of the problems with pain with intercourse, they would avoid it. So these were women who were said to be emotionally frigid, which was a completely unfair characterization. There was nothing wrong with their emotional attachment. They just had lacerating pain when they had sex. So it turns out that this pelvic congestion syndrome is associated with varicose veins inside the abdomen. So there's nothing for you to see usually. But fortunately, with modern interventional radiology techniques, you can plug up these varicose veins, and almost 90% of them have an over 80% degree of relief after these procedures. Let me show you what this looks like. So here's a catheter that's been inserted through the groin on the right, comes up and crosses over into the left ovarian vein, and they inject contrast, and you see lots of tangles of varicose veins in the internal iliac vessels. The contrast is supposed to stop halfway across the uterus, but it flows over to the other side, and you can see lots of extra vessels on the other side. Here's another example with the catheter in the left ovarian vein, and you can see several collateral channels that have formed, tangles of vessels, and more on the other side. On the right, you can see these little coils that have been inserted through the catheter into the ovarian vein, along with some chemicals to clot off those vessels. And here, after the procedure, the only contrast that you see is in the ureters going down into the bladder. So what happened to this girl? Well, she had improvement in her pelvic pain and some of her remaining orthostatic symptoms after this embolization, and she could now stand for 7 hours in the operating room. So she then wanted to become a surgeon. And so my joke in mentioning that is that either we still had some cognitive dysfunction to fix, or if you're more on the surgical side, maybe she got a little bit smarter. So work that's been coming out recently on this has been spearheaded by an interventional radiologist, Steve Smith, who's retired now, but is very active in putting out literature on this. And one of the things that they found is that another form of pelvic congestion or venous insufficiency occurs when the aorta is coming down and you're getting the iliac arteries going to each leg. The right iliac artery sits on top of the drainage vein from the left leg, the left common iliac vein. And because the artery is so much stronger and thicker, it can compress that vein and cause, again, that pelvic congestion picture that you saw in the earlier slide. So what they do in that situation is they often stent open that vessel underneath. And that is associated with big improvements. And what Steve noticed was that many of his patients were reporting global improvements in symptoms. So he did a survey of pelvic congestion in an online Facebook support group for people. And he found out that when you look, these people had a lot of the overlapping features of orthostatic intolerance and ME/CFS, including fatigue that limits their activity, dizziness, irritable bowel syndrome symptoms. Migraines were common, along with brain fog and excessive sweating. And Steve took this a bit further and did a prospective study where he gave people these very involved questionnaires of symptoms to see what improved after people went through treatment of their pelvic congestion. I would just want to draw your attention to the right-hand part of this slide. This was the orthostatic hypotension questionnaire score. Higher scores mean worse orthostatic symptoms. So here's 49% of them having a clinical score that was significant before the embolization treatment, and afterwards just 13%. And you can see this big shift to having a way lower score. So this is another contributor to orthostatic intolerance. And he's got other papers showing that bladder urgency improves. Even things as far away as migraines improve, probably because you're getting way more blood back up to the heart and to the brain. So there's more work going on this all the time. And others from Germany have shown that these are not random events, these vascular compression problems. They're much more common in people with hypermobility. And in our work, 60% of our adolescents with ME/CFS have joint hypermobility. So something about the structure of these vessels and their connective tissue is putting them at risk for a variety of problems. One of them is median arcuate ligament syndrome. Some of you may have heard of this. This is a condition where the celiac artery is being compressed and people get terrific amounts of pain after eating. And they get so much pain that their weight starts dropping almost to the level of somebody with bad anorexia nervosa. They know they're thin, they want to gain weight, but it's too painful to eat. That requires surgical decompression. Nutcracker syndrome refers to compression of the left renal vein and can contribute to pelvic congestion. SMA syndrome is the superior mesenteric artery that can compress the duodenum and lead to vomiting. You've seen the May-Thurner syndrome on the earlier slide and the pelvic congestion syndrome. So we're starting to see this coalescence and coherence to these issues. But it becomes an important thing to look for in our patients with ME/CFS and long COVID. These are not just anyone developing these protracted chronic symptoms. So I'm going to stop there and do some questions. I do want to mention that our work has been made possible early on by grants from the NIAID for a Florinef trial, the Solve ME/CFS initiative. We are very fortunate to be funded by the Sunshine Natural Wellbeing Foundation. They endowed a professorship that allows me to take my time in sorting out very complicated patients. The Boyce family and the Caldwell family have endowed funds. And we've now got a real team, including infused with younger physicians like Camille Broussard and Alba Azola. Our physical therapist colleague along the way that we'll hear more of his work next week is Rick Violin, shown in the bottom right. Emily Steffensmeyer, who's standing with Rick, has done a tremendous amount of work organizing a fundraiser called Rowe's Research Runners, and there are many people that participate in this, including some of the people you see here. We've been very fortunate to have just terrific, bright summer students helping us with our research. And many of these, including John Fan and Marissa Flaherty and Jocelyn, Erica Cranston, Maria Roma, Vic Cybery, and Charlie Edwards have either gone on to finish medical school or they're currently in medical school. And Samantha is an occupational therapist. Megan Lauber is a physical therapist. You see her here. We've just had tremendous support from the patients we've seen, and that has made it possible to do something that's not really very lucrative, which is caring for complex illness. It's allowed us to keep doing this and swimming upstream. So I loved being invited as somebody who considers himself a bit of a renegade to Renegade Research today. So I'm going to let you guys tell me which questions have piled up.
Awesome. Thank you. We have a lot of questions that we're not going to be able to get to, so we might have to follow up with you afterwards for some of these. But Dr. Rosso said he can stick around a bit longer than the hour to answer questions. So I want people to go into the Q&A and upvote the questions that you would like to see answered. I know right now we've had a lot coming in recently, so people haven't had a chance to upvote them. So I'm just going to give like 2 minutes to kind of glance through those and upvote them. During that time, I have a poll for the audience because I'm curious who we have here. So upvote and answer the poll, and then I'll start going through those questions for Dr. Rowe.
And Tess, one of the questions I saw there was that will the slides be available? I can send you a PDF of the slides after next week's talk so that you've got them for people to have access to.
Awesome. That's great. Yeah. So we'll send those out. Also a reminder to go to remissionbiome.org. And at the bottom of that page, there's a place you can put in your email address to sign up for our email list, where we'll send information about the future talks. Okay, so we have a lot of patients here. So far I'm seeing about 65% patients, 20% caregivers, 13% family or friend. We have 10% clinicians. So we have 11 clinicians here who answered that poll so far, 17 researchers. And looks like people know quite a bit about these topics. So the reason why I asked that is because when I'm looking through the questions, I'll pick some that are a bit more detailed if we have people in here that know quite a bit. Okay, so thank you all for doing that. And now that we've had a chance to upvote. Let's see which ones are at the top now. Okay. What does responsiveness to ivabradine indicate about the underlying pathology?
That's a good question. I don't know that we know that. We don't know what drives the heart rate up. But by controlling it, you're giving the heart enough time to rest in between, fill up, and then it can pump more blood out and get that blood to the brain. But we've had very nice responses, not in everybody, to ivabradine. It's like everything else with ME/CFS. You've got to try a number of things before you find a good fit. And we don't always find a good fit, frankly. That's one of the frustrations of where the science is right now. But when we get a good response to ivabradine, we usually hear that not only is the lightheadedness better, but the brain fog is better, their energy is better, they can do more stuff. And that's always the goal. We're trying to get people to a higher point in their daily function. But something must be driving the heart rate up. It could be excessive pooling of blood. It might be histamine. We've had a number of patients, and I'll talk more about this next week, where some of the heart rate and blood pressure problems were caused by the neuroanatomy and some problems in the neck. So there are probably many ways of getting to this final common pathway that we call ME/CFS. And I think we have to be very careful if we hear people saying that they've found the cause of any of it. Because the number of times that I've heard that in the last 30 years, that have fallen apart is multiple.
Yeah, thank you. All right, our next question is also from Michael. What is the role of small fiber neuropathy in POTS? Is it up or downstream? And what might be the cause of small fiber neuropathy?
So yeah, small fiber neuropathy refers to these fibers that control vascular constriction. So it might be that developing a small fiber neuropathy leads to the inability to squeeze the blood out of the legs. But I think your question is well put because we don't really know the full directionality of it. And the treatments sometimes they're helpful, like IV immunoglobulin. We have not had as much luck as others, and we find that we don't go hunting for small fiber neuropathy as much as some other groups do, maybe because our patient population tends to be younger, and we can usually get them going with medications and other things around that wheel that I showed you earlier. But certainly it's something to think about if you're not making any progress in the treatment.
Okay. What are your thoughts on the safety efficacy of injectable peptides for CCI, like GHK and BP157?
So I don't know much about that. I know that people have been trying prolotherapy, which is a way of sclerosing and tightening the loose ligaments in craniocervical instability patients. I've never seen any outcome studies of that. And unfortunately, the clinics that do those kinds of treatments probably don't have any financial interest in reporting their outcomes, because if the stuff didn't work well, they'd lose their entire business. I suspect it must work for occasional patients, but I really don't know how well it works, and I don't have any information on the peptides that were being mentioned.
Okay. All right, this is a kind of long one, but a good one. What are your thoughts on how post-COVID microclots impact and relate to post-COVID POTS? Can post-COVID POTS be secondary to the microclots? If that were the case, would traditional medications still be advisable, or could it be potentially damaging to artificially increase blood pressure if the true issue is clotted capillaries?
Yeah, I probably should not respond to that one. I've been a bit of a skeptic about the blood clot issue because I can't understand how you can have microclots going through the vasculature without getting cutaneous signs of capillary block, like we would see with infective endocarditis, an infection on the heart valves, where they shower off little combinations of platelets and so on. So I'm perhaps I don't understand the biology of it well. I'm not a bench scientist. I don't understand how they've done the work to find the microclots, but certainly if it's a true valid phenomenon and people respond to anticoagulants of one sort or another, then you'd probably have to treat patients very differently if they did or didn't have microclots. But I think we've got to make sure this isn't some kind of laboratory artifact or some kind of anomaly that is unrelated to the true pathophysiology of their symptoms. But again, I come at it as a bit of a skeptic. I'm always interested in seeing new work that is validated and proven, because it gives us opportunities for new ways to treat our more refractory patients. But I'm not all the way there yet with the microclot story.
Okay, I guess I would kind of wonder then, in your clinic, do you see patients have negative responses to these treatments?
To which ones?
Any of them that like raise blood pressure?
When we give fludrocortisone, for example, if I gave that to a healthy individual, their blood pressure would go up. So it tends to support blood pressure and blood volume in the ME/CFS patients with orthostatic intolerance. One of the ways we can tell that they're probably getting better and they may not need the drug anymore is if their blood pressure does start to increase into a hypertensive range. I would point out also that, let's say somebody's using aspirin as a treatment for microclots. We also know that aspirin can be effective for some patients who have mast cell activation syndrome. So simply responding to a given drug doesn't mean that you know the mechanism of action. And in the old days, we would sometimes use drugs like sertraline or Zoloft or Lexapro in patients who didn't have any anxiety or depression. And when they responded, our assumption is that that was helping with vasoconstriction, not necessarily doing anything in the brain that was helpful.
Interesting. Okay, kind of related to the treatments, what can primary care doctors prescribe for ME/CFS patients to help orthostatic intolerance? What can be bought over the counter?
So over-the-counter treatments can include just extra salt and salt tablets and some of the electrolyte supplements, like things like liquid IV. And so that is fairly easy to do. Some of the non-pharmacologic measures can include compression garments that can either be the leggings or the abdominal compression binders, or things like Spanx body shaper garments. You can teach people these postural counter maneuvers where they're using their legs as leg muscles as a pump. And then among the medications that are available, there aren't too many that are non-prescription, but of the vasoconstrictors, a lot of primary care physicians are quite familiar with using the stimulant medications like Ritalin and Adderall. Those work very nicely at the standard ADHD doses for our patients. Midodrine is pretty easy to use. It's prescription. The beta blockers, just about every physician is familiar with those, and most primary care physicians would have a favorite beta blocker to use. They can be very helpful if you've got a high resting heart rate. And some of the drugs that are in the SSRI category, like Lexapro and Zoloft, sometimes can help the blood pressure as well. So there are a number of them that are prescription that are pretty easy to get to know. And we've got quite a detailed description of how to dose them in that brochure that I mentioned in the beginning of the talk. And I can, Ellie, I can make that available to you guys to put on the website as well.
Awesome. Okay. So speaking of Ellie, a lot of people on this webinar are probably jealous that Ellie gets to work with you. And so we got one question: do you do virtual consults? And then this other question is that somebody has had trouble getting into the Hopkins POTS Center and it's going to take years to schedule. So do you have any local doctor facility suggestions for patients who can't get into your programs?
Yeah, so I think one of the toughest things for us has been that we know there's a huge demand out there. And when we first published that paper that I showed in the beginning, the first one in the Lancet, it had 7 patients. It was drawing attention to this idea. It was featured on the CNN medical report every 20 minutes after the hour for 3 days on a holiday weekend. We came in on the Tuesday and there were 5,000 messages on the answering machine. So we got a real sense of how desperate people were to find something that would help. And in the beginning, it was just me. I tried to see as many people as I could, but also contribute to the understanding of the pathogenesis of symptoms and to the literature. And so we couldn't be doing clinical work flat out. We've built up our team a bit, but we still are in the same position. We are completely unable to handle the volume of requests. And so I think a lot of this work has to be done by primary care physicians. And I'm hopeful that many of them will get involved in this and learn how easy it can be at times to get people to a better point, because so many more people are being diagnosed in the pandemic after COVID, and a lot of the insights that people in the ME/CFS world had made pre-pandemic really apply to post-pandemic long haulers. So, there's information that's out there. It's a bit time consuming. Our medical system and the reimbursement for physician time is not well suited to people with complex chronic illness. And that's something that would require systems change. But I think that's faced by people all over the world, even when there's nationalized healthcare.
Yeah, and I guess this is another good time for me to bring up the clinician roundtables that we have coming up. Hopefully we can get Dr. Rowe back into one of those where we're going to really try to bring in a lot of clinicians who want to learn more about this. And we really want to get more people trained in how to help with these conditions. Okay. Why is there an apparent delay between development of POTS and viral trigger? E.g., people who have mild COVID, then 6 months later develop overt POTS. What is happening in the intervening time?
I wish we knew. The theories include, if you get something a couple of weeks after a virus or a couple of weeks after a vaccine, it's often the time at which the immune system is developing and producing antibodies, and maybe some of the antibodies to the coronavirus are also inadvertently attacking parts of our circulatory control that lead to trouble with things like POTS and orthostatic intolerance. Some people also have very mild forms of orthostatic intolerance from usually starting as teenagers as they get into their growth spurt. Don't really recognize it as a problem, but we think that many of those folks who have had some precursors that look kind of suspicious for orthostatic intolerance, maybe they're the ones that go on to get the symptoms aggravated by some period of time after a given infection. So it may be that other aspects of what the infection does, like making you lie flat in bed, might contribute. Maybe you start developing worsening of these venous compression or venous insufficiency symptoms. Like things come not all at once, and it might be that the virus does something but isn't the entire cause of the problem.
Thank you. In your presented case study of the woman who used ivabradine and found the ability to exercise, how did she overcome the PEM and severe fatigue to even begin the exercise? Did she have enough capacity at the outset to do some minor exertion, or was she largely incapacitated, e.g. bedbend? I'm trying to understand how treatment might help someone who is completely incapacitated as opposed to someone who has some energy capacity to begin with.
Yeah, so that's a good question. Anyone who's been bedbound, even if we get their circulation to the point where they're able to do things, they're going to need to very gradually increase their activity level. And we always want them to do it in a way that doesn't provoke PEM. That patient who I presented was able to be upright. She could go to classes. She got her master's degree, but she was symptomatic every day, right? Her probable wellness score was about a 60 out of 100. She could get through everything, but she always had symptoms. When we put her on ivabradine, she was able to she still gradually built up her strength and stamina, but it didn't take her as long because she'd been fairly, active on a day-to-day basis and not housebound. But we've even had people who were completely housebound I'll give you an example of somebody that I'll present next week, but she had a single level disc bulge that was compressing the front of her cervical spinal cord. And she was thought to have psychosomatic problems by her neurologist. We thought that there's no way that that could have been the case because she had very brisk pathological reflexes when we did the neurologic exam. A surgeon felt that she needed her disc that was bulging replaced, but she had needed a wheelchair to get to doctor's visits. She couldn't do more than one visit every 3 weeks because she got so much PEM. And I got a call from her a week after her surgery to replace her disc. And she said, Dr. Rowe, this isn't working. I said, what do you mean? How have things gone? She said, well, I went home on day 2. And on the 3rd day, my mother and I took a 30-minute walk. And I thought to myself, yes, she's going to be better. I said, so what happened? She said, well, the next day we walked for an hour. This is somebody who hadn't gotten out of the house in years, in like 3 years. I said, uh-huh. And then how about the next day? Well, we went for an hour and a half. And today I'm feeling really lousy. I just had her, you got to pump the brakes a bit and build up your stamina. But in the series I'll present next week of these post-surgical patients, they were all housebound. They built their stamina up after their surgery, and then they were good again. And so controlling the factors that drive these symptoms is possible for some. We can't always find what's the driver in everybody.
Yeah. So we're over the hour.
Can I just quick
Go ahead.
say something? Dr. Rowe, I want you to make clear to people that you only accept children as patients.
Yeah.
And that your clinic has another doctor that handles the kids that age out, but currently you're not taking any new patients that are adults.
Yeah, we've tried to have a mix of being productive in generating new knowledge and seeing the patients and taking good care of them. So we are only accepting patients now who fit into the qualifications for our study. We know we can't see everybody. We just don't have that capacity. But if they meet criteria for the study, you have to be 13 to 25 and there's several other criteria. But then those patients we will be able to fit in and continue treating on a longer term basis. But yeah, Ellie's right. We keep looking for ways to expand our footprint of providers. But I think we'll always try to stick to this model of everybody that we see should somehow be contributing to everybody else's understanding by being in a research study, kind of like the way they do it for pediatric cancer, right? Everybody who gets leukemia and lymphoma is in a protocol so that helps the next generation of patients.
That's great. Yeah, so I was saying we're over the hour now. Are you okay to take a few more?
Yeah, let's keep going.
Okay, and I will tell everybody else on here that this is being recorded. It'll be posted, so if you need to drop off, you can finish watching this Q&A later. All right, it's clear that there's a strong correlation between ME/CFS dysautonomia and some sort of immune-initiated onset. What is your thinking on why treatment of infection sometimes improves ME/CFS, and sometimes the infection takes on a life of its own well beyond the infection? I realize that a person could write a dissertation on this topic, but I would love to hear some of the current theory about immune system involvement.
Yeah, so I think, people have wondered about two different problems. If you get a post-infectious illness, right? Like if you get really sick after getting mono, one of the thoughts is that the Epstein-Barr virus is somehow still activated in the body, and maybe you could clobber it with an antiviral. And the group at Stanford has done a number of studies looking at things like elevated levels of HHV6 antibodies and elevated EBV and CMV antibodies. And that led them to try things like the antiviral drug Valcyte. And initially, they had a fair bit of success in their case series, but not much success in their randomized trials. We have not found that the use of these antiviral drugs has done anything much to our patients. And we'll use the antivirals if somebody has recurring cold sores that they want to suppress. But on those antiviral drugs, we don't see anything else get better. So I remain a bit skeptical about the virus as a continued active contributor to the symptoms. However, many of our patients after mono, the virus may have been somewhat of a hit and run agent in that it triggered some kind of other immune change or some other physiologic change that antimicrobial agents will be able to treat. But I think it's a really big topic, as the questioner mentioned. This is a huge topic that we can now start to attack because of the prospective studies that have been done in long COVID. You know, getting blood when people first get sick is incredibly valuable in understanding what's going on with the immune system and what we might do to disturb that so that people don't go on to get infections. I am not an immunologist, though, and I'm not going to wade into that giant swamp of letters and numbers.
Yeah, you know a lot about a lot of different topics, but not an immunologist. Okay. How does your team diagnose dairy intolerance? Testing, cutting it out from the diet, checking particular symptoms?
So good question. We look very carefully for let's say we get an adolescent coming in. We want to know from that child's mother, what was this person like as an infant? Did you nurse them? Were they given formula? And if so, were they very colicky and spitty babies, as many children with milk intolerance are? They often will settle down and become tolerant of milk for a number of years until they get whatever virus triggers the onset of their ME/CFS. And it may be that the virus is changing their immune tolerance to that food protein. What we're looking for is the kind of delayed hypersensitivity to milk protein, not somebody who gets hives immediately on contact with it or who gets anaphylactic reactions. These are patients who get a triad of symptoms. So we look very carefully at a triad of symptoms of epigastric pain, meaning upper abdominal pain, reflux, and then early satiety. So these kids will sit down, order a plate of food at the restaurant, take 3 bites, and then they feel full. About half of them have recurring mouth ulcers inside their mouth. And we can often feel that the epigastric area is really tender when we palpate it. So we look for that triad of symptoms, and then we take them off milk completely for 2 weeks. And that's usually enough to see if they get better. And the kids might not really want to give up their pizza or their milkshakes. We ask them for 2 weeks just to see if this is playing a role, because if you've got an untreated milk protein hypersensitivity, it really makes it very confusing to try other medications, because if the person has a way more milk intake one day after starting a new drug, that's going to look like the drug had the side effect and should be stopped, when it might have had nothing to do with the reaction. So we get them off milk if they have those symptoms. We don't take everybody off milk. And we look for an improvement over 2 weeks. And by that point, the kids often feel so much better that they're willing to stay off milk. I mention it as milk, but it can be milk protein in the vast majority of patients, but you can get the same reaction if you have a soy protein intolerance or a wheat protein intolerance or an egg protein. It can be anything. And many of the patients who have milk intolerance also have mast cell activation. As we're looking more for mast cell problems, we look for their cutaneous flushing, the redness of the cheeks and the nose, the rashes that come on. Many of those folks have multiple medicines and foods that they just don't tolerate. It's very hard to nail down the laboratory diagnosis, because some of the markers that the mast cells release go up and down very rapidly. And some of the lab specimens need to be kept chilled. And so the lab personnel don't always do that right. But it's something that we need to measure and look for more carefully, because it gives us another way of treating the patients using drugs like antihistamines or famotidine, which is the same as Pepcid, or cromolyn, or some of these other drugs that can work on the mast cell behavior. Mast cells are also known to be a driving force for some of the patients with POTS. So we've had some patients who, when we control their mast cells, so we're not using any of the drugs I showed you in the last hour, but we're using drugs directed at mast cells, that can bring their orthostatic intolerance under control. So you've got to be nimble in thinking about the things that each person might have driving their symptoms.
Yeah. Great point. All right, we'll do two more here. So I'll take this one. What are the neural drivers that are producing reductions in cerebral blood flows, e.g. neurally mediated hypotension?
I'm not sure I understand what
The
the
neural
question meant.
drivers.
It may be that, the thing that what's really driving the reduction in cerebral blood flow is whatever is causing the excessive pooling of blood in the lower half of the body. We think that for some people who are hypermobile, that it's just the stretchiness of their vessels, that when they have this column of blood going down into their legs, the vessels have this outward force and will dilate a bit more than maybe my vessels would. So they can then dump way more blood volume into the legs and have way less coming back to the heart and the brain. So the answer may be somehow figuring out how to improve their vascular constriction in the lower half of the body and get more blood up to the brain. It might not be a neural factor. In some ways, many people with POTS don't have a dysautonomia, right? They have an appropriate response of the autonomic nervous system to not enough blood flow getting up to the heart and brain. So it's not always the autonomic nervous system that's at fault.
Yeah. Is ivabradine okay for people with bradycardic episodes or generally low HR?
No, because if you give ivabradine to anybody, it'll lower their heart rate below what their baseline is. So we tell people that we don't want them taking a dose if their heart rate, when they're due for a dose, is below 70. And I've seen patients who are given this drug by people who weren't thinking that way. Their resting heart rate was 60, and ivabradine is supposed to only affect heart rate, not blood pressure, unlike the beta blockers that affect both heart rate and blood pressure. But ivabradine definitely will lower your blood pressure if you drop that person's heart rate below 40.
So I said we had two more questions, but there's one more that I wanted to get to here. Can venous compression syndromes be missed if the patient's imaging is supine, given symptoms often only present on standing?
Yeah, it's a great point that often our interventional radiologists will do, if they have the symptoms that are classic, they'll have people do, say, a pelvic MRI or a pelvic CT scan. But if they don't see the varicose veins, it might be because that study was done when they're flat and the veins are emptying. And a special condition where people go in with a laparoscopy to look for endometriosis, they're actually head down to do that laparoscopy, so the veins will drain even more. So you might not see anything. So if the symptoms are classic for this, our people will do a venogram, see if they can identify these vessels with contrast injection. And so a lot of the attention has to be on what each patient is talking about. The May-Thurner problem can, because it's compressing the left common iliac vein more than the right usually, those patients can have left leg swelling, and that can be a risk factor for clots forming in the left leg. So there are other things that you can do to identify the problem. Many women get worse pelvic congestion after several pregnancies and the relaxation of the vessels that occurs with each pregnancy. So the most common presentation is people who've had several pregnancies, and they might even have varicosities on the vulva or around the buttocks. But the vast majority of patients that we see that are younger than that, who haven't been pregnant, have none of these external features.
Interesting. Okay, well, we'll wrap up here. I know there were a lot more questions, and Dr. Rowe is going to be back next week with a lot more topics. So maybe, like I said, we'll have to get you back on the clinician roundtable too. I think you're just going to have to become a friend of Renegade Research, and we will learn everything we can from you and spread it around to other clinicians.
It's the right name for me. I love it.
Awesome. Okay, well, great. Thanks again for
Okay.
presenting.
Yep, we'll see you
And
next week.
yeah, we'll see you next week.
Okay, great.
Thank you. Thanks
Take
everyone
care.
for attending. Bye.